Well, good afternoon. This is Rebecca Roper with the Agency for Healthcare Research and Quality's National PBRN Resource Network, and we are delighted today to have Dr. Bridget Gaglio join us. I know today is May 1st, but we reached out to Dr. Gaglio at the end of last year, and she has worked with us to schedule this wonderful presentation today that will provide us her insights of real practical learning with respect to the PRECIS model and RE-AIM. And Dr. Gaglio's name probably is familiar to many of you. She is currently with the PCORI Institute, the Patient-Centered Outcomes Research Institute in Washington, D.C., where she facilitates research initiatives aimed at improving communication and dissemination of evidence-based information among patients, caregivers, and their healthcare providers. Before joining PCORI, Bridget was a research scientist with interest in patient-centered communication, health literacy, qualitative research, and dissemination and implementation science of health interventions, which is a particularly important and fertile ground here with AHRQ and our colleagues. Dr. Gaglio is involved with the RE-AIM work group and has experience in using the RE-AIM framework to design and evaluate interventions that balance both internal and external validity. So some of you may remember that Mr. Thorpe gave a wonderful presentation about PRECIS in early December, and so and that was well attended. And Bridget's going to give us an overview of PRECIS and some of her unique experiences. So what we're going to do to help Bridget hone in on what is of interest to our attendees is to issue a poll as to who you are. So please do take the time to let us know whether or not you did attend the seminar with Kevin Thorpe on December the 11th. This will help her know how much detail to give about the PRECIS framework. And we have a few more questions. Keep voting. No hanging chads. And so we can see not quite everybody has voted, but what I'm able to show is that most people who've exercised their vote so far actually were not on that call. So just for point of reference, we record our national webinars and make them available via Primary Care YouTube channel. And we will be sharing that link with you, so at your convenience you can watch Mr. Thorpe's presentation, which will complement nicely Dr. Gaglio's presentation today. And so here's our second question. Have you heard of the RE-AIM framework for evaluating interventions? And let us know where you are with respect to that experience. And the votes are coming in, and it's about a 50% breakdown. So half of you have and half of you have not. So thank you so much. This is very helpful for us. And we'll issue the third poll. Have you used the RE-AIM framework in clinical practice or research? So we're running at about 13% who said that they have. So about, if we do conditional probability and multiply it out, maybe half had actually heard of RE-AIM, and half of that half, 13% of all the people on the call have actually used the RE-AIM approach. So with that, Dr. Gaglio, Bridget's going to give an overview and a first of PRECIS, and then we ask you can use the question font, not font, but function, and pose your question. And at the end of each specific section, I will convey your questions to Dr. Gaglio, and to the extent that we're going to try to focus on clarification questions of what's being presented in the phased approach, that will help us understand where your question is coming from, as well as the global learning. And then at the very end of the discussion, more specific questions for your particular activities or experience would be welcomed, and she will gladly respond to them. So it's quite easy, as Christina is showing you on a slide, how to pose your questions, and I'll be monitoring the questions for iterative posing to Bridget. So with that, we will turn the presentation over to Bridget Gaglio, who we're just delighted to have with us on this beautiful Friday afternoon. Thank you, Bridget.
Thank you, Rebecca. And can you see my screen?
We can indeed.
Okay, great. Hello, everyone. Thank you for giving me your time this afternoon, or for those of you on the West Coast, the late part of your morning. Today, I am going to talk to you a little bit about, I know Rebecca kind of gave a nice overview of my talk today. The focus of this presentation is in reference to a paper that myself and some colleagues wrote prior to coming to PCORI. I think it was referenced in the announcements for this talk today, but if you don't have the reference at the end, I have provided an entire list of references related to the talk, and so you'll have that available. So I'm going to give a quick introduction on an overview, basically, of what a pragmatic trial is. And then it looks like, since only about half of the group has heard of RE-AIM, hold on. Oh, is this the wrong way? How do I switch it?
Bridget, sorry, I didn't want to interrupt you. This is Christina. So I think, yes, go to the presentation mode. Perfect.
Okay.
Now we can see the right.
Is that better?
Yes. That's
okay,
perfect.
Great. Thank you.
Sure.
Okay, sorry about that. That's why I get for having multiple screens on my computer. I apologize about that. So I'll go into an overview of RE-AIM for those of you who are not familiar with the framework. I'll give a little bit of a refresher on the PRECIS framework for those of you who were not able to attend Kevin Thorpe's presentation back in December. And then what I really am excited about is kind of showing everybody how to use multiple frameworks in evaluating pragmatic characteristics of trials. And then we'll go ahead and open it up for questions from the audience. So to start off, I wanted to provide a couple definitions so that everyone is starting from the same place in terms of understanding what a pragmatic trial is. There was a seminal paper that was written back actually in 1967, and again I've provided that in the list of references at the end of my slides. And this paper was written by Schwartz and Malok, and they originally coined these two terms of pragmatic and explanatory for describing or differentiating between the different types of trials. So the term explanatory is used to describe trials that aim to evaluate the efficacy of an intervention in a well-defined and controlled setting, whereas a pragmatic trial is designed to test the effectiveness of an intervention in a more broad and routine clinical setting. An explanatory trial is the best designed to explore if and how an intervention works, and the entire experiment is designed in order to control for the known biases and confounders so that you are maximizing the intervention effect. So as I've written here on the slide, when you're doing an explanatory trial, you're trying to answer the question, can an intervention work under ideal conditions? So whereas a pragmatic trial, this is designed to test interventions in the full spectrum of everyday clinical settings in order to maximize applicability and generalizability. And so the research question that a pragmatic trial is really trying to address is, does this intervention work under usual or real-world conditions? So here I provided a simple table that highlights a few key differences between the two types of trials. And so on the left I have, just what the characteristic is. The middle column is related to explanatory trials, and the right column is related to pragmatic trials. And so one thing I did want to note is that while the definitions I just presented appear to be a dichotomy, there really is the distinction between the two is really not that easy. So it's not black or white, a trial is explanatory or a trial is pragmatic. It's really, it runs along a continuum. And so the purpose of my talk today is to not only demonstrate this point of the continuum, but to provide ways for trying to better identify and evaluate a trial as to where it does fall along the continuum. So ideally, a researcher wants to maximize both internal and external validity. Internal validity we see being associated with explanatory trials, external validity with the pragmatic trials. And so some key challenges that we have is some of our traditional RCT studies are really conducted with a very select population and under ideal conditions, which really makes it challenging to translate the results into real-world settings, which is what our pragmatic trials are interested in. And so I put this quote up. I'm sure some of you have seen it before, but it's very pertinent to today's conversation, and that if we want more evidence-based practice, we need more practice-based evidence. So we really need to see these trials being conducted in the environment in which we hope that they're adopted. So why is this important? There are a few advantages for using pragmatic trials, as listed here on the slide. One advantage is that the findings are more relevant to clinicians, patients, and decision makers because we're hopefully looking at outcomes that are of interest to these individuals. And then another advantage is the emphasis on the contextual factors and the real-world applicability. We're trying to measure and document factors such as the amount of resources that are used, the staff time, staff training, just the global environment in which an intervention is being delivered. And this information provided can help decision makers determine whether an intervention can be replicated in their setting. So just to reemphasize the characteristics of a pragmatic trial, the questions, as I stated before, are outcomes that are specific and important to stakeholders. And those are whoever your end users are. So they could be patients, they could be the practitioners, they could be payers, policymakers, whoever. But the findings and the questions that you're trying to answer are something that they are going to find relevant. The research is going to be conducted in multiple settings, and these settings are going to be very diverse in nature. There's going to be very few exclusion criteria related to participants. We really want to get participants involved that are typical in the settings in which you're hoping to get this intervention ultimately implemented. And then the comparison condition should be the real-world alternative, as opposed to an RCT where there might not be a treatment or there's a placebo. So translating research into practice requires different information for different stakeholders. It depends on who you're trying to target. So to address the needs and the complexity of the environments in which the studies occur, it requires a blending of not only methodology, which I'll talk about a little later in the presentation, but also a blending of the models and frameworks used to design, monitor implementation, and ultimately evaluate the study. So today I'm going to highlight two frameworks, first covering the main domains of each one independently, and then showing how they can be combined to help understand where a study and its components might fall along the pragmatic explanatory trial continuum. So the first two frameworks. The first one I'm going to present is RE-AIM, which I've already highlighted in the introduction, but if it wasn't obvious there, obviously the bottom of every slide so far has advertised for RE-AIM. And then the second one is the PRECIS tool, or the Pragmatic Explanatory Continuum Indicator Summary. Presenting these two models today is not meant to imply that they're the best models or tools for this exercise. It's just the ones that I'm most familiar with and have the most experience in using. All right, so RE-AIM. RE-AIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. So this framework was created, or at least published and emphasized back in 1999, and it grew out of the need for improving on key issues related to implementation and external validity of health promotion studies. So it really was developed partially as a response to the trends in research that were being conducted under optimal conditions instead of in real-world complex settings. And so while it was developed a while ago, over the last, 15 years, it's really evolved since the original publication. It was originally developed to evaluate interventions and hopes of producing a more balanced approach to internal and external validity. But over time, it's expanded to include more diverse content areas. It's been applied to policy, community-based, multi-level interventions. It's also been now used throughout the entire continuum of research in terms of planning, evaluation during like the implementation phase, and then the ultimate evaluation at the end of the project. And then it's also kind of evolved in terms of what's included in each of the domains of the framework, and I'll talk a little bit about that when I talk about each domain specifically. So REACH is the first domain, and so this is focused on the absolute number and proportion of individuals who are willing to participate, with consideration given to the representativeness of those who choose to participate. So essentially, REACH is the extent to which you are able to recruit and retain the intended audience of your intervention. So REACH is measured at the individual level. And since there's 5 domains, I kind of like to try to associate a word with them so it's easier to remember which one is focused on which. And so for REACH, we try to think of who is participating. So we're focused on the who. Who is your intervention targeting? Who is participating? So to assess REACH, you want to look at how many people are eligible to participate. This is going to be the denominator for REACH. So how many people were you representing the target population of your intended intervention? Then you want to look at how many people are actually participating in the study, and that's going to be your numerator. And so then that percentage is going to give you an idea of what your REACH was for the intervention. And then you want to look at not only who was reached, but maybe were the individuals who were most at risk for your condition of interest or issue of interest, were they reached? And so you can even do a sub-analysis of the overall reach in that regard. And then again, the representativeness. And when I talk about representativeness, we're looking at, were there differences in the population who participated versus those who you were trying to target? Did those who participate have differing characteristics than those who chose not to participate? Are the characteristics of the participants different from the general population in that area that would be eligible to participate in your study? So looking at, did you reach the people that you were really intending to from the start? And so for a pragmatic trial, your study population should be very representative of the target population of your intervention. So the next domain for RE-AIM is effectiveness. And effectiveness refers to how well an intervention affects the change in the primary outcome of interest. And again, for a pragmatic trial, these outcomes should be of interest to your end users and stakeholders. Effectiveness should also assess the impact on quality of life and whether there are any unanticipated outcomes. And these two criteria, these have been added in since the original publication of the framework. And so in the beginning, it was just looking at the outcomes, the primary outcomes, and what that looked like. And so over time, it's evolved to include, was there an impact on quality of life of the participants? Was it a good impact on the quality of life? And then looking at outcomes, and unanticipated outcomes, and those could be both positive and or negative. And so reporting on those as well. Effectiveness is generally measured at the individual level, and going back to the word to associate with effectiveness is what? What are we measuring? What are your outcomes? And so that's what we'll look at with the effectiveness domain. And so these are examples of things to consider regarding assessing the effectiveness of a study. It's not a comprehensive list, but just to get people thinking about what might be included in the evaluation for this domain. And so you're looking at your primary outcome. You're looking at your primary outcome relative to a larger goal, a public health goal. You're looking at the robustness of your outcomes across subgroups. So hopefully you have a large enough population that you're able to do that. And then we're definitely wanting to look at attrition, short-term attrition, seeing what that looks like, and then looking to see if there are differential rates by patient characteristics or by treatment group. And if so, really trying to delve in and try to figure out why. So the next dimension for RE-AIM is adoption. And this is defined as the absolute number, proportion, and representativeness of settings and staff who agree to deliver the intervention. So similar to REACH, but we're looking at where the intervention is taking place and who those intervention agents are. And so as you see on the screen, we're looking at where. Where does this occur? And I'm going to talk here in a minute about the difference. We do measure this at not only the actual setting, but also at the staff level, so intervention agents. And so as you see, the equation up here is very similar to the one for REACH. How many settings are eligible to participate? So this is the number of settings that were eligible and invited to participate, and this will be your denominator. And then you're going to look at how many of your settings actually participated, and that will be your numerator. And then you're going to look at similar questions. Were there differences between the sites that decided to participate? What did those different, what are those differences? Are they different in the size of the organization or the capacity or the type of patients they see, or maybe even the experience relative to the intervention? And so again, answering these questions are going to provide important clues about the compatibility of the intervention with your target setting. And so something that should actually be of interest in the pragmatic trial for sure. So one thing I want to highlight here, I did a systematic review a while back with a couple of colleagues in Colorado, and we reviewed all of the peer review papers from 1999 when the original RE-AIM paper was published through 2010. And the goal of the purpose was to look at how RE-AIM had been used over time. And so we wanted to describe the application, how RE-AIM had been used, consistency of use, and just how it was being reported over time. And so the most prevalent problem we identified was a lot of people are really confusing REACH and adoption. And so I just wanted to point that out and just re-emphasize that REACH is focused on who are the participants, and adoption is where are the settings that the study is being conducted. And so I hope if you take anything away, aside from putting this all together today, is the difference between REACH and adoption in terms of RE-AIM. All right, so the last two dimensions. So implementation is the extent to which an intervention is delivered as intended. Or basically, we're talking about the fidelity to the protocol. And so we're concerned about the consistency across the different intervention settings. We're looking at consistency across different staff, and we're looking at the consistency of how the intervention is delivered over time. Personally, I think this dimension is the most fun one to assess out of all the RE-AIM criteria, and especially as it relates to the larger pragmatic trials. There's a lot going on in terms of variety of settings, variety of people, intervention agents, and so trying to capture all of that and make sense of it I find to be very interesting. So this is my favorite dimension for pragmatic trials. And so going back to our quick, short one word to associate with this dimension is focused on how. How is the study being conducted? How was the study conducted? And is there a difference between the two, what you envisioned and how it ended up? So again, a couple questions just to pose to get you thinking about implementation. Again, not an exhaustive list by any means, but just to get you thinking about understanding implementation. When we're looking at cost of implementing the intervention, not only are we looking at costs in terms of monetary resources, we're looking at terms of cost, participant time. What is the cost to the patient in that regard? We're looking at costs in terms of the amount of resources that are needed in order to implement the intervention as designed. How complex is an implementation protocol? I mean, that's really going to play into the fidelity of whether it was delivered as intended, and if it wasn't, why? And then looking at the different types of staff to implement the program. Does it require somebody who's highly educated and that have a training in a specific specialty, or can any member of your staff deliver this intervention? So again, just something to think about in terms of implementation. And then the last dimension of RE-AIM is maintenance. And so this particular domain is measured at both the individual and the setting level. Maintenance can be considered, for the setting level, we're referring to sustainability of the intervention over time. And then for the individual level, we're referring to maintenance of the observed outcomes. So we saw short-term outcomes with our effectiveness, and so for maintenance, we're looking at those long-term outcomes, the degree to which individuals maintain the behavior or health outcome over time. And so for this particular domain, we're looking at how long. How long is the study maintained? How long are the effects observed? And so again, just a question for each, at each level, how can participants stay engaged and sustain the positive behavior over time? And the setting level, how can the intervention be incorporated into the organization so that it is sustained over time? And so a couple things to point out. At the individual level, when we're talking about maintenance, we're looking at measuring the primary outcome at greater than 6 months follow-up after the final treatment contact. So if your intervention is a 12-month intervention and the participant had their last point of contact with the intervention and the study team at 12 months, then we would hope there would be some kind of measurement at 18 or 24 months to see whatever outcome was observed at 12 months is still sustained longer term without having to have the constant intervention interaction. And then we're also going to want to see a measure of long-term attrition and seeing if those rates are different based on either patient characteristic or the treatment arm that they were in. So we'll have the short-term attrition and the effectiveness domain, and then here we'll have the long-term attrition. And then for the setting level, we're looking at, is the program still going on 6 months or greater post-treatment follow-up? And so again, we're looking at, did this organization, clinic, setting, wherever you've decided to conduct your intervention, did it decide that they felt it was worthwhile and they kept it going after the study was over? And if they did sustain it, did they adapt it or modify it in any way for the long term? And what does that look like? What elements were retained? What did they get rid of? And how is that impacting how it fits into the environment in which the intervention was originally deployed? And then some measure of looking at, is there an alignment with the organization's mission, and how does that play into sustainability? So that's covering RE-AIM. So I think at this point I'll take a quick break. to see if anybody has any questions about REAIM before we move forward with the next framework.
Bridget, we have one question. With respect to the expectation of comparison, can one have more than one type of intervention that's going to be assessed at the different stages of the RE-AIM, so that, in essence, you may find different interventions have different effectiveness, but perhaps the overall adoption can be variable too, so what may be shown to be a highly effective on the individual level is not long-term effective at the where the care or the intervention is given at the adoption? Are there?
Could you repeat that, Rebecca?
So what I'm trying to get after is that, as I understand the presentation, that the intervention selected to use the RE-AIM, you can only evaluate one intervention, one modification compared to just one change. Is that correct?
No. So are you asking if you have more than one intervention arm? So if you have your intervention compared to usual care compared to something else? Is that what you're asking?
Right.
Yes.
So that,
you could have multiple comparators.
Right. And so over time, at each level of analysis, while one particular intervention may be shown to have higher effectiveness, that the level of success of those interventions may be reversed in the adoption assessment. And if that happens, what type of considerations do you have for digesting, interpreting all of the data that are generated?
That's a good question. So what I would recommend is, looking at what the primary outcome was for the study. And as you stated in your question, that one of the intervention arms would have a larger effect size than the other interventions, but might not have been adopted. And so you would want to look at, why was it not adopted, as well as really what the differences in effect were, going back to your original research question, to see, is the intervention with the largest effect, are you really, would you, I guess, be giving up not a lot or a little if you, say, went to the intervention with the medium effect if it was adopted in a larger number of settings? And so I think you kind of have to see what the give and take is between the two in terms of how could you maximize adoption, but also maximize the effect that you're getting by the intervention you would decide to ultimately use.
Great, thank you. So folks are very excited about your PowerPoint presentation, and yes, at the end of Bridget's presentation, we'll give you a copy of that. And all of our webinars are recorded on a YouTube channel. And with respect to these wonderful references that Bridget is speaking about, there is a list of references that are provided in the PowerPoint and other materials that you will be given. We have one other question, Bridget, if we could ask about the RE-AIM before we move on. Would that be all right?
Sure, absolutely.
Okay. Is RE-AIM used in retrospective and real-time studies?
Well, that's a good question. I don't know of any that have been used retrospectively, but I don't see why you wouldn't be able to use it in a retrospective study. I think it would be applicable to any study design. I think you would be able to address each of the domains and answer questions specific to each one, whether it was retrospective or a prospective study.
Fabulous. I think we're now ready to go to your next discussion area.
Okay, great. Thank you for all the questions. So the next part of the presentation is going to focus on the Pragmatic Explanatory Continuum Indicator Summary, or as I'll refer to going forward, PRECIS, because that's a lot to say. So I was planning to give a really quick overview of this framework because, as Rebecca had said at the beginning of the webinar, Kevin Thorpe did a really nice presentation on PRECIS back in December. And I've provided the link to his slides, and I believe there's an audio recording available as well. And if you're unable or don't want to look at the slides, I've also put up the reference for the original paper associated with the tool. So the main purpose of PRECIS is to determine the degree to which the study design aligns with the trial's stated purpose. And so this tool was originally intended to be used in the design stage of the study. But like RE-AIM, it has evolved over time. The criteria are still the same, and the way you evaluate everything is still the same. But in terms of use, we've seen it expand to being used to reviewing systematic reviews. My group, we've used it to do evaluations of study, post-completion, and so it is being used in some different capacities now than originally intended. The tool is comprised of 10 domains, which are listed here on the screen. And so I guess I'll give a quick overview of the domains since a lot of you had not attended Kevin's talk back in December. And so participant eligibility criteria. So this framework, let me back up for a minute. So this framework is intended to look at each of these criteria and subjectively evaluate where you think it falls along the explanatory pragmatic continuum. And so the intent of this framework is for you to rate each of these criteria and create a visual diagram of what that looks like. And so the designers created this hub and spoke diagram, which I'll show you on the next slide, and we'll come back to this criteria in a minute. So this is what this hub and spoke diagram looks like, where the center is explanatory and a truly explanatory trial, and then the ends of the spokes out near where the labels are for each of the lines would be a completely pragmatic trial. And so what the intent is for you to look at each of the 10 domains and to evaluate your project either while you're designing it or, like I said, as we've used it after a study's over. But it might also be fun to do it at the beginning and at the end to see if it's changed and evolved as, as the study, from what you originally decided the study was going to be to what it ended up being. So the more pragmatic a trial is, you would mark the spoke further out, and the more explanatory it is, you would mark it closer to the middle. And so this picture really highlights that you really can't say a study is truly pragmatic or it's truly explanatory because there's so many different components, and depending on the component, it could be more explanatory or it could be pragmatic. And so the studies really do fall along this continuum, making it really challenging to categorize a project. And so going back to the criteria really quick for some of you, the participant eligibility criteria, so you're looking at what the participant criteria. Are there a lot of inclusion criteria and a lot of exclusion criteria, or are there very little criteria? So looking at how stringent the criteria is for those to participate. Experimental intervention flexibility. So this is looking at how much latitude or not does an intervention agent have in deploying this intervention. Can they be very flexible in the protocol that they use when they're intervening with someone, or do they have to be extremely rigid and follow the protocol to the letter? The practitioner expertise in the experimental condition is looking at what level of expertise is needed for the person who's going to be delivering the intervention in the experimental condition. And then the same for the practitioner expertise in the comparison arm, like looking to see Does it have to be a highly trained person to deliver either the experiment or the comparison, or can it be pretty much any staff member who's available? Looking at the comparison intervention, is it usual care? That would be a very pragmatic approach versus a placebo condition, which would be a very explanatory approach. Follow-up intensity, looking at the degree to how patients are followed up. Is it just as the patient comes in for care, or is it a very regimented, multi-visit routine that the patient has to come into over the course of the study? Again, primary trial outcome. For a pragmatic study, it would be objectively measured, clinically significant, and it's one that can be assessed under usual conditions, whereas an explanatory primary outcome would be one to be known to have a direct and immediate relation to the intervention. It might require some kind of specialized training or testing to evaluate the outcome. Participant compliance, I think that's self-explanatory, is just looking at how regimented it is as to, I guess how, let's see, participant compliance. If there's a lot of, mechanisms in place to make sure that a patient is compliant and sticks to the intervention as originally described, or if you just let the participant participate like they, however they see fit for themselves, and you just let them go through the study and see what happens. Same thing for practitioner adherence, letting the practitioner deliver the intervention as they would like to deliver it, or are there mechanisms in place to incentivize them to make sure that it's being delivered as originally intended. And then the analysis of the primary outcome is, a very pragmatic trial would look at all comers, and it would be more of an intent to treat analyses, whereas an explanatory study would focus on the analyses that would estimate the maximum benefit of the intervention. And so it might be just restricted to those individuals who are considered like completing the intervention. So I hope that gives everybody a good sense of PRECIS. Like I said, I wasn't planning on spending a whole lot of time on this one because Kevin did a really nice job. So I guess right now I'll take, I know that was a 5-minute summary of PRECIS, but if there's any questions so that people have a good sense of it before we move on to the rest of the talk, I'm happy to take those.
Sure. So we had one question with respect to PRECIS, and the advantage of a pragmatic trial is identifying in that it's assessment of treatment effect in the real-world setting, so that the estimates that you have are the mean. And so, what are your thoughts with respect to doing subgroup analysis if the treatment effect may vary across groups, and what's been your experience in that area?
That's a really good question. I'm not a statistician. I am actually, that's a good question though. I think, if there is variability across groups, I think the sub-analyses would still be very helpful if the power is there to do the analyses. I know that some studies don't have the power to do sub-analyses, and so that might be problematic. But I think if it is an option, I think it would still be worthwhile to at least explore to get a sense and an understanding of why you got the outcomes that you did for the study.
Okay. All right. Thank you. I think we're ready to move on.
Okay.
Okay. Okay. So promise I'm going to get into combining these in a minute. But I did want to highlight a couple of other important things that don't really fall into each of the frameworks really nicely, but are very important for pragmatic trials. So pragmatic trials conducted in a real-world setting, or should be conducted in a real-world setting, and real-world settings are diverse, they're complex, and sometimes they can be really messy. And so, trying to understand that is key to understanding the outcome of the study, but also key to understanding if this study is going to be able to be implemented in additional settings after your trial's over. And so, because pragmatic studies are very context dependent, the study should report on the multi-level context within which they were conducted to allow potential adopters to determine the applicability to their individual setting. And so, although some may not consider context to be important, I do, and a lot of other people do too. But at the present, there really is no widely accepted or standard approaches to describing or assessing context. And so that's kind of looking at the implementation domain for RE-AIM is very helpful. Looking at some of the criteria from PRECIS and marking it on the continuum, trying to understand why it was rated the way it was is very helpful. But one of the ways that could significantly impact the field and advance it forward would be to develop these pragmatic approaches to studying context. I think that would be a significant advancement for these type of trials. But aside from the two frameworks in trying to understand context, previously in the early stages of the presentation, I also mentioned a continuum of methodology. So we have a continuum of a type of trial. Now we have a continuum of a type of methodology. And so qualitative methods, I like this slide because when I saw it originally, just made me think, quantitative, I found it funny that it was red because everybody likes quantitative results, and so that's the hot of our results and methodology. And then people are kind of about qualitative, and so that is deemed the blue or feel a little cold to it. But I also like this slide because it represents, turning the knobs of how much quantitative and how much qualitative data do you need or want, and you can play with that to make it more hot or more cold, more quantitative, more qualitative, depending on your research question, but also the settings in which your study is being conducted. And I think to understand factors that affect pragmatic trials, qualitative data is going to be very helpful into understanding that context and the factors that could impact the success of the project. You could be looking at facilitators to the intervention, barriers to implementation. If the time or burden to a participant is too high, going out and talking to those folks and asking them, what about it was, not ideal for them to want to participate in your trial. When you're looking at organizational capacity, how many times have you got a bunch of research sites on board and then you receive the funding and then all of a sudden you've had sites drop out because they've lost the capacity in some way, their resources or expertise to participate in the study now. And so to get at really what happened, you really need to go out and talk. Hello?
Dr. Gaglio?
Yes, is the call still there?
Oh, yeah. Yes, okay, great.
Right.
You cut out for a second.
So anyway, that's what was my plug for qualitative methods. So, and mixed methods for sure, but really, to try to understand the context. And I think it really is going to be helpful in the implementation, really understanding the implementation. Implementation is a key to success for your study, so really understanding what happened is going to be really important. And so I think right now the only way to really do that is by using a combination of methods. All right, so now the fun. We've got 2 frameworks, we've got some methods, and how are we going to put it all together? So, you know, everything's on the continuum, and so, you know, we've got all these great frameworks out there, but does one framework really meet the needs of any one study? And for a large pragmatic trial, I think a combination of frameworks is going to do the best job in helping you understand what happened in your project, but also the issues that would be related to translating the research. And so I think also for combining the frameworks, and all of these, when you're combining the frameworks will be helpful, as I have up here on the slide, you know, just not in evaluating your study. This should be looked at when you're planning your study to help you figure out if your intervention is really going to address what it is you think you want it to address during the implementation phase, and the evaluation to help you figure out what happened and why. So just really trying to get a comprehensive take on what the results of this project are, and to help you understand if you can take it to the next stage, which is to translate it into other settings. Okay, so I have a couple of examples of how we have combined these frameworks and methods to help understand particular aspects of a trial. So the first example that I'm going to use is participant eligibility. And so you can see on the top of the slide I have the spoken hub for the participant eligibility as it relates to the PRECIS criteria. And then on the bottom I'm going to fill that in with some information related to REACH from the RE-AIM. And so, so participant eligibility, so the most pragmatic approach to eligibility would be to identify study participants with a condition of interest, and to have very little restriction in terms of inclusion and exclusion criteria. And then the more explanatory approach to it would have lots of inclusion and exclusion criteria, excluding your complex patients, people you don't think that are going to adhere to the protocol as you have designed it, things of that nature. And so for the example I'm going to share with you, we evaluated a study a while back where the primary outcome of interest was reducing weight at 24 months. Participants were 21 years of age and older. They had to be obese and have at least one risk factor for cardiovascular disease. And this was conducted in an urban city in a healthcare system that served pretty much the entire city. And so the only exclusion criteria for this particular project was that they could not be taking weight loss medication and they couldn't be pregnant. And so for this particular trial, we marked this as a pretty pragmatic approach to recruitment because we were really trying, this particular study was really trying to get everyone that met that criteria, that was 21 obese and at risk for cardiovascular disease. Very little restriction. So, okay, so you say it's quite pragmatic. What does that mean? So this is where REACH and RE-AIM can come in, overlapping with the question. So who is the target population of the intervention? What proportion of the patients participated? So even though we think we had a very pragmatic scope for eligibility, let's look at the REACH and see how many people were truly eligible and how many people ultimately participated, and did we have good REACH? And then for those who participated, how representative were they? And so after answering these questions, we can say, well, maybe it wasn't as pragmatic as we thought it was, or while the criteria has a pragmatic spin to it, for some reason we still didn't get the people we thought we wanted to participate. So then that's where your mixed methods come in, so you can go out and try to figure out what happened. You know, the criteria was about as inclusive as you could be, but it still wasn't what you had hoped for. Maybe it was, and that's a good thing, but you know, to investigate that a little bit more. The next example is going to look at follow-up intensity. And so we've got that criterion from PRECIS, and then we've got the implementation from RE-AIM. And so pragmatic approach for follow-up, as I said earlier, is not to seek follow-up contact with study participants in excess of the usual care of one's practitioner. And an explanatory approach for follow-up would be one that would be really intense and would lead to a lot of increased visits. There's a lot of frequency happening on a predetermined schedule that are dictated by the study protocol. And they typically would occur outside of usual care. And so the example for this project that I just shared with you about the participant eligibility, there were lots of data collection during this project. And so it was collected over the phone, via the web, and in person. And the follow-up in-person visits were at 6, 12, and 24 months. And all of these visits were additional trips to the clinic for the participants. And then when they were there were a ton of assessments because, you know, once we have somebody, we like to assess them so they, as much as we can. So for this particular project, we gave it a very explanatory rating in terms of the follow-up intensity because there was a lot required from the participant. And then some questions from the implementation perspective of RE-AIM, were all the components of the protocol followed as planned? Because there's obviously a lot going on here. And so how many of the 6-month visits were completed? How many of the 12 months were completed? How many 24? And you know, were these visits conducted as they were originally described and outlined in the protocol? And if not, why? And that's where your qualitative piece comes in, really trying to get at what happened. Why was there not 100% fidelity for each of these sets of data collection and visits for the participants? Again, looking at the consistency of implementation, not only across the staff, but looking at it across the settings, since hopefully your pragmatic trials are being done in a lot of different settings, and then looking at that over the course of time. And if there's any difference, then getting that qualitative piece in there, looking at what happened and why. And then the last example is going to be the practitioner experience for the experimental arm of the study. And so, as I said earlier, a pragmatic approach for the practitioner expertise would be that the intervention would be in the hands of the practitioner providing the care or those who treat the patient, and they do what they want with the patient. And then a more explanatory approach would be if the practitioner would be required to have some experience in terms of length of time working with these patients, and the patients were similar to those that were enrolled in the study, they had to have experience with patients that were similar to those that were enrolled in the study, or they need to have like a special training or certification or type of education. And so for this particular example, okay, the intervention was to be delivered by counselors. So, and these were any staff in the clinic who wanted to do the counseling session. So it was pretty much open to anyone. But they also had to undergo a lot of training and retraining to reinforce the skills that the investigators wanted to have delivered through the intervention. And so so it was kind of taking anyone, but then there was this huge training component. And so based on that, we were kind of in the middle on this one, whereas it was pragmatic in that it was open to all staff, but that, you know, the training component kind of negated a little bit of the pragmatism of it. Because the training, not only would they be doing it, but then it was going to be, they would reinforce it and evaluate it over the course of the study, and so made it a little explanatory. So in terms of adoption, we're looking at this from the staff part of adoption, not the settings, the staff. So we wanted to see how many staff were offered the option to participate, since this was open to everyone. Wanted to see what that looked like. And then, you know, you could look at how many people chose not to participate after they found out what the requirements were with all this training and retraining and assessment and evaluation of how well they were delivering the intervention. and then looking at the characteristics of the staff based on who ultimately chose to participate versus those who didn't. And then, again, overlaying the qualitative piece and talking to those who maybe might have expressed interest and then dropped out, and versus those who chose not to participate at all. And then talking to those who did participate to find out if the training and the retraining was a bit time-intensive or required a lot of their very demanding, whatever the case may be, but to get an understanding of what that might have looked like. So to remind you of kind of just the PRECIS picture, the diagram with all of the components, if you started to put this together for this particular study, you would see we were very pragmatic in our participant eligibility, the expertise of the practitioner, middle, and the follow-up intensity not so much. And so we're starting to create that picture to get a sense of where the study is more pragmatic versus where it's more explanatory. And then we overlay the RE-AIM criteria to really understand what these markings on each of the spokes mean. And then we have the qualitative data to fill in the pieces that are still unknown to kind of help put it all together. So to wrap up, combining the domains for multiple frameworks and tools can highlight where and how an individual study or group of studies is or is not pragmatic. Assessing domains within the same study allows for understanding the pragmatic versus explanatory design elements of a trial. You can compare domains across trials, which will allow for meaningful judgment about which intervention has generalizability and applicability to a population of interest in a variety of settings. And the assessment of characteristics should be done over the life course of the study. And I say this because it really does capture how the study has adapted and evolved over time, which is meaningful in and of itself. So if you choose to use one picture, one framework, one model to evaluate your project, you can kind of have a few pieces of the puzzle to get a sense of what's going on. But instead, if you decide to use a multitude of frameworks and methodologies, and while it is a lot more time, it does round out the picture. And so having a complete or almost complete picture increases, or hopefully will increase, transparency, but also helps potential adopters make informed judgments about programs and their applicability to different settings and conditions. And so before we go to questions, I just would like to acknowledge my fellow colleagues who worked with me on the paper that was the underlying reference for this study. And then as promised, here's all of the references which will be included in the slides that will be sent out by Rebecca and her team. And so I'll end there for today for questions.
So thank you very much, Bridget. I have to say, you are quite skilled at articulating complex concepts very well, and your illustrations are fantastic.
Oh, so, thank you.
We have a few questions. One of them was with respect to how does this approach for looking at combining the two frameworks, RE-AIM and PRECIS, to understand what has been achieved in a particular study. How is that really helpful? So that's a general question, but before I hand that off, I have a bias.
Okay.
Have you, I think it can be helpful, and one of the challenges that we have in funding, deciding what to fund, is discerning what is necessary gaps to be filled. And when is something quite similar, it appears on the surface to be quite similar from something else. I hope you answered the general question, but have you seen in some folks as they apply the combination of RE-AIM and PRECIS to explain the extent of pragmatic and explanatory evaluations of a particular study, to inform how their findings need to be applied and hence where the remaining gaps are? Have you seen that type of discussion?
No, I have not, and that would be great to see that kind of discussion. I'm hoping that it does move in that direction.
Great. But going back to the general question, what are other, you gave us some examples of how this combining the frameworks can be helpful. Have there been any surprises when you combined the two frameworks and evaluated a project that came to your awareness? Did something kind of strike you as unexpected?
So from the work that I've done to date, I've used these frameworks to evaluate other people's studies. And the interesting thing might not be so surprising to me, but it was the investigators, once we did the evaluation of their study and actually presented them with the PRECIS diagram to show them where their study fell along the continuum for each of the domains, they were actually surprised because a lot of them thought that their studies were a lot more pragmatic on a lot more criteria than what they originally had thought. And so talking with them and sharing those results and doing it after the fact is a little challenging, but at least planted the seed to say these are things you should really be thinking about at the beginning of your study when you're developing it and designing it, so that at the end your picture is looking like it's more pragmatic on all characteristics and not just a few.
Oh, excellent reflection. We have another question. Was really, I interpreted someone being really appreciative of your combining different aspects of the RE-AIM and PRECIS in the examples, and they were hoping for a little more granularity. Are there any publications or resources that match from one-to-one or one-to-many more explicitly of the elements of the 10 PRECIS items and the 4 RE-AIM domains?
There are not, but I am happy to talk with anybody about that if they're interested in applying that on a more specific level. The papers that I'm aware of right now that have combined both of the frameworks, well, I take that back. I think there is one which I believe I cited, which is the one with Dr. Glasgow, where we looked at the applying the PRECIS criteria to describe the effectiveness of trials with weight loss in obese patients, and we looked at 3 studies that were all operating under the same research question and outcome, but had some latitude in how they went about doing it and the populations that they used. And that was actually our first attempt at applying both of the criteria. And so I would recommend looking at that. But if there's further questions, I'm happy to talk with people offline after the fact.
Great. I think that person will note your contact information, and we can provide that to that person, and thank you for it so much. We do have a couple more questions, one of which goes back to your first segment of the presentation on RE-AIM, focusing on maintenance. And does maintenance have any bearing or relationship to the failure or success of the intervention? So here I'm wondering if how maintenance is defined may have any bearing. And then they have a follow-up question. Is there anything like a short, successful intervention that does not require long-term maintenance?
Okay, so the first question, if I remember correctly from hearing it, is looking at, can there be short-term success that they don't have to have long-term maintenance?
Well, we can answer that question, yeah.
Okay, so a lot of studies do show short-term effect, and a lot of studies do not show long-term maintenance, and so yes, that does exist. But I think in terms of adoption and looking at, sustainability, you would want something that would have short-term effectiveness and also have the longer-term maintenance, and those would hopefully be the interventions that are used over time. And then what was the other question?
Well, you did actually a beautiful job of distilling the questions in a better way than I had posed them. So you've answered there.
Oh, okay.
So now we have rather a longer question.
Okay.
This person was reflecting that the language used today really has focused on the effectiveness of individual trials. But it seems that the same approaches or principles could be applied to group randomized trials so that the effectiveness would be applied at the location, not just an individual. Is that feasible?
Yes, so yes, the observation is correct that the examples and the focus today were at the individual level. But we have applied definitely RE-AIM, and you could also apply PRECIS and combine them where you're looking at the unit of intervention is at a higher level. So it could be the unit of intervention is a clinic or a setting or a practice. And so it would definitely be easy to translate all of this material to do that evaluation.
Well, fabulous. And the final question isn't really a question. But as someone who just voiced their appreciation for the education that you have provided to our listeners, and I echo their sentiments. This has been a great Friday afternoon. We were excited here and learned quite a bit, and appreciate your efforts very much. So, but your benefits for participating don't need to end here, because for those of you who are clinicians, you can attain CME credit if you follow the instructions that Christina is now showing on the website. And then as you exit off of the GoToWebinar, we have evaluation questions that it's so helpful if you give us feedback on what we can do better and what we should be doing and how we did for our own quality improvement and service to our community. And May 1st, we've enjoyed this wonderful presentation, but we are going to have a second May presentation at the end of the month, a real pragmatic discussion, but on a completely different topic, institutional review boards, challenges of the continuum of quality improvement and research designs with respect to meeting those requirements for protection of human subjects. So it's been a delightful afternoon, and I hope you all come back and join us at the end of the month. And for those of you who are regular recipients of the PBRN biweekly update, we look forward to hearing from you and your suggestions for other presentations. And thank you very much, Bridget, and give our best to everyone over at PCORI.
Great. Thank you, Rebecca. Thank you for inviting me. I appreciate everyone's interest today. And like I said, if anyone has any questions, feel free to reach out.
Lovely. All right. Thank you all. Bye-bye.
Bye.